I'm impressed with what next generation sequencing can bring to the table, but I'm also trying to maintain a balance of what it can't bring to the table. And I think in order to understand this, we really have to look at it from the full perspective of the entire population that's seeking to benefit. What changed this year is that the FDA and CMS approved the Foundation One assay.
This is a large NGS panel of over 300 genes. It is not hotspot testing. It actually tests the entire coding region of these genes and also several non-coding regions, as well as looking for special fusions and rearrangements of other genes that may or may not have immediate therapy implications.
It doesn't make sense to debate whether or not it should be part of standard practice. It is. Now the question is, how do we use it in the most efficient and effective way? And how do we maintain a balanced perspective on optimism and realism in terms of what it brings to the table?
I think in concept, testing every patient who comes through the door is a great idea, provided that it's paid for from a research budget and it's done under the rubric of a research protocol that is asking a finite question. I don't like fishing expeditions. Looking at the genes in every tumor and saying, well, something might sort itself out, is a bad idea because it's scientifically illogical and it's potentially incredibly expensive.
We get inundated with concerns that I think are justified to discuss, but they cannot be an excuse to not profile a patient. In the setting of the cost of these new therapies, $10,000 a month on average, with the cost of scans and other tests we run, to spend a few $1,000s to find out what drives a tumor, we really have to continue to address costs, but it can't be an excuse not to profile.
If we have a target that we find in 1 in 100 or 1 in 1,000 patients, but almost all of those people benefit when we hit that target with a particular drug, that's very interesting, and that's kind of what we'd like precision medicine to really accomplish. But what do we do if, after culling through thousands of patients, we find 50 or 60, we treat them, and 10% benefit? Is that good enough? Well, it's good for that 10%, but is that practical on a societal level?
From a investigational standpoint, I think sequencing patients is important when there's no other lines of treatment available. However, some of the trials that have reported the results of this type of effort, the benefit to the patients are quite low.
One of the things we have failed to do throughout the world of oncology is define a floor and set a standard below which we won't go. We haven't done that for a lot of our drugs, and we haven't done that for a lot of our tests and assays, and I think we're going to need to.
We have a number of targetable mutations, or so-called actionable, and that number is getting to the point where, in my opinion, the average oncologist who's treating well over 100 traditional cancer types cannot be expected to keep track of all of these mutations. What are their implications? What approved therapies are there? What clinical trials are there available?
The thing that I hate to see, and I see it so often because I have a referral practice in a big sense, is people come in and they've started chemotherapy when we then find out they have an EGFR driver mutation, and I'm like, well, we should have just done that first. Now, it might not have cured the cancer because we have to deal with resistance, but let's get the best run we can with an oral agent with more minimal side effects before doing chemotherapy.
And I think that really boils down to three different things. One is the report that you get when you order one of these tests, which can span 25 to 30 pages. Most people don't read much beyond page 1. This report potentially has a lot of important information buried in it, but it's difficult to digest, and more importantly, it's static. It's generated at the time of the test, which could be months or even years before the patient might need that particular treatment. So to kind of address that issue, a second solution that's coming along is this idea of molecular tumor boards. And so with these, the idea is you'll assemble a group of experts either at your institution or more than likely, especially if you're out in the community, this is going to have to be some sort of virtual group of experts that are assembled from across the country in some way that can help you make sense of the results that are coming from these tests. The third argument that I have is that we need to bring knowledge that's being generated either in the basic science space or in clinical trials or in patients that are being treated routinely. We need to bring that knowledge to the practicing clinician at the point of care.
I think you need to educate the first responders, so people that are seeing the patient first. It's not the medical oncologists, it's the pulmonologists, it's the internists, it's the people doing colonoscopy. They all have to know what's needed and what needs to be done. And I don't see that happening as much as it could. You know, very often I'll see someone who's come to me from an internist or a pulmonologist and the tissue was sent and it wasn't sent for the relevant markers. So that's important.